Hello, and welcome to Voices for Safety, a podcast from the NIHR Greater Manchester Patient Safety Research Collaboration, or GM PSRC. I'm your host, Louise Gorman, the Public and Community Involvement and Engagement Manager for GM PSRC. I'm very excited to introduce to you our brand new podcast, where we'll explore the latest issues and breakthroughs in patient safety research. Today's episode is extra special. Besides being our very first episode kicking off our journey together, it also marks this year's World Patient Safety Day, celebrated on September the 17th, 2024. The World Patient Safety Day is an initiative established by the World Health Organization to raise awareness and emphasize the importance of patient safety globally. But what exactly is patient safety, and why does it matter? To help us unpack this critical area of health, I'll be joined today by Professor Darren Ashcroft, Director of GM PSRC, and Neil Walbran, Chief Executive Officer of Healthwatch Manchester. Together, we'll explore what patient safety truly means and why it should be a priority for everyone. Then later in the show, we'll dive into this year's World Patient Safety Day theme, Improving Diagnosis for Patient Safety. I'll be joined by Tom Blakeman, a GP and Professor of Primary Care at the University of Manchester, Umesh Chauhan, Professor of Primary Care and GP Partner from the University of Central Lancashire, and Tony Avery, Professor of Primary Care, a GP, and also the National Clinical Director for Prescribing from the University of Nottingham. Anyway, so enough from me, let's get on with the show. So Darren and Neil, welcome to Voices for Safety. It's really great to have you here. So what is patient safety?
So from my perspective, patient safety is really a discipline where we look to identify where risks occur, errors occur, harm occurs to patients. And the research arm of that really focuses on how we address that.
And from our perspective as a Healthwatch, it's about members of the public and the right to feel safe entering any health and care system, and to know that their safety is a priority for the people who will be treating and caring for them.
Is patient safety a local issue?
It's very much a global issue, but within the NHS, we see news reports of, problems that occur within our health and care systems on a regular basis. We've conducted research that starts to identify and quantify how often some of these errors occur. So we have a good measure of how often adverse or preventable events occur within our health system. And a lot of our research is focusing on how we address some of those problems, co-develop interventions with patients, with practitioners, and try to get them embedded into our NHS to improve safety overall for everyone. So the WHO have established a special interest group in and around safety, and they've had 3 international campaigns to date. The most recent one was around improving medication safety and harm from medicines. As part of those global initiatives, governments in each of the different countries are often asked to challenge, and test the systems that they're operating. So for instance, in the UK, we brought together groups of experts to consider what the recommendations were from the WHO, and that led to some recommendations that were implemented. In fact, one of our interventions from the Greater Manchester Patient Safety Collaboration was rolled out nationally to try and reduce harm from medicines in primary care. And we're in the middle of evaluating what the impact of that intervention is at the moment.
So locally then, to what extent is patient safety an issue for our NHS?
I think it's a massive issue. It's an ongoing issue, and it always will be. Whether you're somebody who requires a medicines use review from your pharmacy because you're being prescribed 35 different medications and you're getting contraindications, to somebody who's in full-time care who needs turning and your pressure ulcers treated, to somebody who is unable to understand the letter they've received from the hospital and so doesn't know where to go for their appointment. I mean, it just, the more you think about this, the more it unravels. Patient safety is all right through. I mean, it's the golden thread that runs through all our health and care services. When a patient goes into hospital, when we, any of us are a patient at any one time out in our lives, when we go into hospital, let's say, we become more vulnerable. Now, if you add to that anybody with a protected characteristic, but say somebody has a learning disability and then goes into hospital, they're super vulnerable in that situation. And so those things have to be taken into account too.
So who are the key groups then that we want to highlight as being important for improving patient safety, both on the health service side and on the public side?
I personally think it's everybody's business really around safety. Clearly, healthcare professionals, doctors, nurses, pharmacists, other allied health professionals have an important role because they're at the front line, often delivering health and care services. But patients themselves, when they're actively engaged in their own care, can be excellent advocates for improving safety by identifying when things go wrong themselves or reporting when things just don't feel right in that particular situation as well. Within a healthcare organisations, I think it covers all kind of levels of those organisations. You know, the leaders and managers have responsibilities for the policies and procedures that are set around safety and monitoring how effective those are as well. But beyond that, we've got regulators that are responsible for monitoring safety, protecting public safety, and educators to, educate the workforce that's going to work in our health and care services in the future. So I think it really is everyone's business.
Absolutely.
Yeah, definitely. I mean, it's the people that work in the healthcare system that need the ability, the freedom to speak up. Guardians are an example of a step towards creating better patient safety. But out there in the real world, let's say outside health and care, it's the citizens who speak up, who decide this isn't good enough, from those communities, or just as a family. Martha's rule springs to mind, so that's fairly recent. Now that's being implemented it's been rolled out across all our hospitals, and that's because those parents decided this just simply wasn't good enough, the way their daughter was treated and how she died. So, I would say from the citizen's perspective, it's those champions that do speak up.
So, Neil, I think this is a really good point too. If you can tell us a little bit about what Healthwatch Manchester actually is.
Okay, well, Healthwatch were set up in 2013 through national legislation brought about by the Health and Social Care Act in 2012. So in each local authority area in England, there is a Healthwatch by law. We are independent, not-for-profit organisations who have a board of directors or trustees and small staff team usually. And it's our job to inform and signpost people to health and care services, to speak up for people and direct them to what their rights are as citizens and patients and users of health and care services, and also to collect the views, opinions and experiences of people around health and care and use those in our reviews and our reports to influence health and care services and improve them by conversations with the planners and commissioners of health and care services. So we are Healthwatch Manchester. We are also in Greater Manchester. We are joined up as a Healthwatch in Greater Manchester network, and that's all 10 of us. And we meet regularly, and we have people in post who are there to support us, and they are commissioned through the ICB, the Greater Manchester Integrated Care Board. What we do locally is we inform and signpost people to services in health and care. So that's anybody phoning us or emailing us saying, where can I get an NHS dentist? That's usually every day at the moment, and it has been for a few years, to somebody saying, where can I make a complaint? I feel I've been treated very badly. And we also do outreach. We also do outreach to people to find out what their views, experiences and opinions are of health and care. And if we see anything concerning, then we'll act on that and do an interim view or do a review of that service. I mean, I can give you an example of that recently, if you like.
Yeah.
A woman was on her way to work and somebody collapsed at the bus stop. And so they dialed 999. The ambulance service told them to go to a defibrillator site. They went there. There was no defibrillator. So they called up the ambulance website and tried to find another defibrillator. That wasn't there either. So after 15 minutes, they got back to the person and they luckily were being resuscitated and they survived. But they came to Healthwatch in an absolute state saying, this has happened. So we have just completed our review of defibrillator sites. Are they there? They say they're there, but are they actually there? And it's not looking good. 40% of the time they're not there. Nobody knows anything about them or they're not in a condition to be used. So we're taking that report nationally. There doesn't appear to be any regulation on the information. Anybody can pick up a defibrillator, but if they decide not to have one anymore, there's no onus on them to say, we're not using this defibrillator anymore, we're not providing it. We don't think this is good enough. We're going to call for regulation around this information so that this never happens again. It's not like, try again next time. There is no next time in this situation. Somebody will die.
So helping to identify those areas where patient safety errors or unsafe practice can occur, as well as helping to find out what it is exactly that's going on in those areas as well, and trying to help figure it out.
And the learning from them.
Exactly. And I suppose sharing that learning as well.
Yeah.
That links nicely to Darren. Would you be able to explain to us what the patient safety research collaborations are?
So the Patient Safety Research Collaborations, or PSRCs for short, are an initiative that's funded by our national research funding scheme, the National Institute for Health Research. They've awarded just over £25 million over a 5-year period and funded 6 PSRCs to conduct research to address patient safety problems, and in particular to start to reduce inequalities in safety. So that's the main focus of the PSRCs. Within Greater Manchester, we're a collaboration that brings together safety scientists across the University of Manchester, Nottingham and Leicester to tackle some of these problems. We've 4 main research themes that we focus in on. One around improving medication safety. It's the most common intervention that's used in healthcare, and it does a lot of good, but from time to time, medicines can also cause problems. And we're trying to address some of that hazardous prescribing or misalignment of medicines to the wrong patient or at the wrong time with patients. We have another theme that focuses on developing safer health and care systems. A lot of innovations come into our health service, and it's intended that they will bring a lot of good. But sometimes there may be unintended consequences that happen when new innovations come into systems. And it's important that we evaluate these systems and we understand also not only the effects, but also some of the adverse consequences, so we can start to develop better systems going forward. We have a theme around enhancing cultures of safety. Often when we look at major incidents within healthcare, the underlying culture within those organisations is often flagged as a key factor why things go wrong. So we've got a team that's focused specifically on trying to understand and improve organisational culture. And then finally, we have a theme that's focused on mental health, in particular around preventing self-harm and suicide. Too many people die, unfortunately, through suicide. Rates of self-harm seem to have increased in recent years, in particular groups of patients. So we're developing initiatives to try and address some of those and reduce some of the inequalities that occur within our society as well.
And how does Greater Manchester PSRC relate to other PSRCs in England?
So we were very fortunate through the national funding body. We were awarded a project fund that allowed us to create a network. So we have a network called Safety Net that brings our 6 PSRCs together around some common themes. We take responsibilities around different areas of those activities, and we've established a number of kind of working groups across that kind of network that allows us to bring expertise across the country together around some key areas of work.
How do you see our own PSRC in Greater Manchester working with organisations such as Healthwatch to improve patient safety?
It's hugely important, and across our own PSRC and likewise for the other PSRCs, public involvement and the involvement of charities and other organisations really feed in at various levels across the infrastructure. So as Neil's highlighted, we're really fortunate that he is a member of our strategic advisory group along with many other organisations. And that plays a key function because they're seeing lots of problems in the system that allows us to hear about their experiences and think about what some of our priorities are for research going forward in the future as well. Within our governance board, we have patient and public representation. So they're holding us to account in terms of what we say we'll do and whether we meet that at due course, which is appropriate. But also, when we get down into our themes and the individual projects, all of those projects have public involvement anchored into them as well. And it's really important because if, our focus is around co-developing interventions, we need to work closely with patients, with practitioners who are going to use these interventions in the future to make sure that we're developing interventions that are likely to be adopted, are sustainable, and we've got evidence that they have impact as well going forward.
Well, it's great to be able to be there to add that the patient and public voice to the mix as well. And from my perspective, it's all about building responsivity into the system in terms of taking that patient voice and making it heard. That's the way I see the role of Healthwatch at the PSRC. Yeah.
And how important is research in the whole topic of patient safety?
Through research, we often can identify some of those problems and kind of quantify the impact and size of that problem. We can use research to develop some of the solutions to address some of those problems. But also, as I mentioned earlier, many things are rolled out into systems that are intended to do good, but sometimes there may be unintended consequences. So we can also evaluate some of that innovation that happens in our health and social care systems and to make sure that it actually lands on the right tracks and it delivers what it was hoped to deliver and hopefully, results in better care, not worse care.
Thank you, Darren and Neil, for talking to us today about what patient safety means. This World Patient Safety Day focuses on improving diagnosis. But patient safety incidents and avoidable harm don't just happen in hospitals. Primary care is often the first point of contact for most patients seeking healthcare. But what do we mean when we say primary care? Primary care is described as the front door of the NHS. It is made up of around 7,500 practices, 11,500 pharmacies, 7,000 optometrists, and 8,500 dentists. High-quality patient care at every contact is the aim of every healthcare team. There are approximately 340 million consultations in the UK each year in general practice, and on average, a GP has 42 patient contacts a day. Although the vast majority of these consultations pass without incident, the sheer volume of contacts can significantly increase the likelihood of patient safety incidents occurring. A review from the Health Foundation in 2014 estimates that patient safety incidents may occur in around 2 to 3% of all family practice consultations, and 1 in 25 of those involve serious harm to the patient. This means that there are several million patients potentially at risk of avoidable harm each year. A paper published in 2021 by Professor Tony Avery and colleagues concludes that diagnostic error accounts for the most avoidable significant harm seen in primary care. So I'm utterly thrilled today to welcome Professor Tony Avery, Professor Tom Blakeman, and Professor Umesh Chauhan to the show. All three are general practitioners amongst their other many roles. Would you like to introduce yourselves?
Yeah, hi, I'm Tony Avery. So I'm a GP in Nottingham. I'm Professor of Primary Healthcare at the University of Nottingham, and I'm also the National Clinical Director for Prescribing for NHS England.
Welcome, Tony. And Tom?
Hi, nice to be here this morning. I'm Tom Blakeman. I'm a GP and I work in Hare Hills in inner city Leeds, and I have a transpennine experience in that I've been a researcher at the University of Manchester over 20 years as well.
Wonderful. Thank you for joining us. Umesh, it's lovely to have you here as well.
Thank you. So I'm Umesh Chauhan. I'm a GP in East Lancashire, in Brighfield. I'm also Professor of Primary Care at University of Central Lancashire and the Quality Place-Based lead for Lancashire and South Cumbria.
Wonderful. Well, thank you all for being here this morning. I wondered if you could tell our listeners what diagnosis means, and importantly, what is a diagnostic error?
So a diagnosis identifies the patient's health problem and is the key to making sure that people get the treatment they need. Now, in general practice, we don't always come to a clear diagnosis at the end of one consultation, and it may not be necessary to have a clear diagnosis, but the most important thing is to have a good idea of what is going on for the patient and what you need to do, particularly in order to either identify or exclude a serious illness. So I think that's the important thing, is having that approach to really thinking about what is going on for the patient, what needs to happen next. And a diagnostic error is if you either don't manage to get a right diagnosis or the right idea of where you need to be going with things, and doing that in a timely way, which can then result in incorrect diagnosis or incorrect approach, which can then waste time and can potentially be harmful, delay or actually missing the diagnosis. So the key risk is that what is really causing the problem for the patient doesn't get picked up, and the patient may be harmed as a result of that. A particular example is cancer. That's one of the areas where we want to be trying to identify cancers as soon as possible, and there can, in some cases, although we're doing much better than I think we were, there can be some delays in that, which obviously has an impact on patients. I just think it's really important to get the right balance, and that's where organisations like NICE and the National Screening Committee are helpful in advising us on what are the sort of tests and approaches that are useful to be picking things up. The approach we have to the 2-week wait system for picking up cancers, I think is helpful in that you've got a clear set of criteria there. If people fit the criteria, then we can refer them to for further investigations. The challenge, I think, for us is for people who don't quite fit those criteria, and there's a risk that they slip through the net, or they end up on a quite a prolonged waiting list for to be seen. And I think it's in that group that you've got to be particularly on your toes, particularly if as a GP you're thinking, I know they don't quite fit the criteria, but I'm still worried about this person. And it's making sure that we talk about safety netting in general practice, making sure those people don't just drop off and don't get reviewed, making sure you've got some systems in place that you're going to follow up that patient, and not keep on following up, doing nothing, which can then waste weeks and weeks and sometimes months, that you do get to a point where you say, hold on, we're going to bail out on this. We need to get another view on this.
Absolutely. So the complexity of the patient and what they're presenting with, the signs and symptoms, are very difficult for you in general practice to make decisions, I suppose, quickly and cleanly, particularly when you have, from the initial statistics of 340 million consultations in general practice alone in the UK is absolutely staggering to me. And an average of 42 patient contacts a day for GPs. You can clearly see how challenging that is going to be on so many levels, especially when you have that complexity for each individual that you're seeing as well.
It is phenomenal what we manage as GPs from just what you have said, and that was one of the things that came out with our major study we did of avoidable harm in primary care. I think firstly to reassure people that when we looked at over 100,000 consultations across the country, we found that 97%, 97 out of 100 were consultations that were done well. We didn't identify any significant patient safety issues. It was only in the 3%, but of course, when you multiply that by all the consultations, that we did detect problems. But often it was where GPs were having to deal, as you say, with highly complex or patients with highly complex problems, presenting with multiple problems at the same time, and in the context of extreme demand. And so that requires tremendous ability to sort of sift out what's important and most importantly, as I say, to be doing the necessary follow-up and safety netting.
And I agree with Tony's points. And it's in a way, it's how a diagnosis and making a diagnosis helps the ongoing planning of care. And with that, importantly, sort of identifying the problem and how diagnosis help with that, how you then have systems and care planning in place that you see things, you see something through is really important. And, going back to sort of the diagnosis itself, diagnosis can help sort of, how do we make sure that they're a helpful thing and don't add to complexity? And so how are they useful in planning care for somebody, and how do we minimize noise in and around making diagnoses? I mean, the new diagnostic entities come into place over the years. There's something like chronic kidney disease. It's a relatively new classification, a new diagnosis in the systems of care. It's for 22 years, which is nothing in the history of medicine. But how you introduce it in a way that's helpful and helps frame care well for people, and that people can understand it and do it in a helpful way that doesn't then just create extra noise and extra work. That requires careful consideration.
I'm just conscious of the fact that, the terms that we're using at the moment are very medicalized. A patient will present is a complaint, a problem. And what we're labeling it is a diagnosis, what we think the cause of the complaint or the problem is. And in the context of working with people with learning disability, what I've found is actually there are issues such as diagnostic overshadowing. So a person will present with something and we don't really understand what that is. And we put a label on that says, this is the problem and this is how we're going to manage it. And that often leads to issues in terms of causing more harm than good to the person. So inherently, I think it's important for us to understand where we can avoid harm, where we're causing more harm than good. And this is, I think, where much of our work is really focused on, is to avoid things that can be avoided and not cause unnecessary harm.
I think that's a really good point, Umesh, because one of the biggest dangers, I think, is actually coming too early to what you'd see as a firm diagnosis. Because once that's gone down, once you've said, these upper abdominal pain symptoms are due to reflux, acid coming back into the esophagus or gullet, or another example. It means that both you and people following you can very much like, those symptoms are just due to that. You actually need to make sure that your diagnosis is well formulated, and that also you keep an open mind as things develop, to be thinking, perhaps that wasn't quite right. Perhaps it is something else.
And I think for me, the point that Umesh was picking up there as well is that how we talk about it and how we define it can then potentially have consequences for patients and caregivers as well, and practitioners, as well as the health system. So it's not just about necessarily the patient, but it's how that information is then communicated and understood. as to how you proceed with that, both on a medical diagnosis term, but also on how that person interprets that information and their caregivers interpret that information as well.
The risk often, the moments when you can get caught short is that you sort of treat a diagnosis or a working diagnosis that's been made somewhere else in the system by another GP or in A&E, and you then see it, and treating it at face value sometimes can be problem. And it's those points when you think that when you've seen somebody, and there's something about preparing in advance of consultations, but also when you've seen somebody and you're thinking this doesn't quite add up, using your clinical acumen and time and listening to somebody, and so that's the moment probably to slow things down a little bit.
Most important, I think, things come from the study we did and from experience. It's just the importance of all that rigorous training that we have. It takes at least 10 years to train to be a GP, but of course you develop experience beyond that. But starting out with that thing that will have had reinforced to us so much, but starting with listening, really listening to what the person is telling us, doing appropriate examination, doing appropriate investigations, coming to a sort of what we call a formulation, an idea of what we think is going on without fixing too early on the actual diagnosis, and making sure that you've got appropriate follow up with the safety netting.
Tony and Tom will probably reflect on their training. And one of the simple rules that I was taught was that if you've seen the person for the third time or within the system for the same problem, you need to think again, because clearly you can't assume that it's, whatever the diagnosis was the right diagnosis if the symptoms haven't gone away. So there has to be triggers in order to support you to think about, and part of it is about our training, but also the system. There need to be ways to kind of make you think, have I got the right diagnosis here? Have I gone down the right route? Should I be thinking of something else here?
Just what are those systems? I mean, in practice, my experience over the last 20 years being in the same practice, or over 20 years, is the uncertainty is inherent in everyday practice, and in meeting people and listening, thinking things through. And I think listening is absolutely the key aspect of care. And with that also is, when you're uncertain, actually having a safe environment to share those uncertainties with colleagues. Corridor conversations, clinical meetings, team meeting, multidisciplinary meetings. So and you learn from the reception staff, you learn from sort of actually clinical admin, you learn from the advanced clinical practitioner that's in the practice. You learn from the social prescribing link worker who has an insight into somebody, into that is where sort of actually you begin to, I think, generate safe practice, and where sort of, so that's what I've learned in experience of, how to thrive, and everybody begin to thrive in general practice.
Is that heavily reliant on having a good culture to work in?
I think so, and that just isn't a given. That requires active work. It requires leadership to get to that point, and it requires resourcing as well. You have to create spaces and for people to meet and actively meet. You have to create a shift. I mean, in our practice, we're trialing a shift now, and I don't think we'll go back. 15-minute appointments, but sort of actually as an agreement in the practice that is the best way for us to be, beginning to provide care.
Yeah, one of the key things is actually, we talk about the 10-minute consultation, the 15-minute consultation. It's having that flexibility as a GP. It's recognizing that for some people coming to see you, so I saw a gentleman with abdominal pain last Thursday who'd got what we call an obstruction. His bowel wasn't working. That probably took me about 40 minutes to get it sorted out right from start to finish, right from the point of actually getting him admitted to hospital. But then we'll perhaps make up the time with a relatively simple medication query that on the phone may take only 5 minutes. But I think the key thing is, what we see is the 10, 15 minutes of what goes into our typical general practice surgery, and it's having some flexibility around that.
There is something about ownership of the space and the spaces that exist in general practice. And that includes people, patients, having sense of this being part of, having sense of ownership of the space, and that space being, maybe the consultation itself. And knowing when, as Tony's example is, knowing when to speed things up and when to slow thinking down a little bit, and having the flex and ownership to do that. Because that's, there's moments when you really have to slow down and listen and be listened to be understood and to understand. And then there's moments when you really have to speed things up. And that's the beauty of general practice. I mean, it's amazing, really. You meet so many different, but it's creating spaces that you have ownership of the work you're doing as a GP and as a patient or as a carer, as we all experience in our lives. Also having a sense of that this is part of my everyday life, and I can come to this practice and I can feel that I can say what I need to say and begin to sort of share some whatever thoughts, difficulties that you're experiencing as a person.
Well, there's a couple of things that are going on in my head there, Tom. Does that come with training? Does it come with experience? Because I can imagine that's a very sort of interpersonal skill that you need to have or develop in general practice, which is probably why it feeds into the 8 to 10 years for training to be a GP.
Just one thought that I have, a sort of immediate thought that comes to mind, and it takes back to it with a patient safety lens. I think there have been various reports over the years, and you referred to a Health Foundation one, I think that was mentioned earlier, but the Francis Inquiry and the Berwick report, and how you begin to strengthen systems of care and people ownership within it are really important. The Berwick report, I mean, there are key points that are on page 2 or 3 of that report that, the patient safety issues exist in the system and always will do. NHS staff and patients aren't to blame, in the majority, and in the vast majority, it's system issues that need to be strengthened. And then you can take the point that actually, how do you then think about strengthening systems of care? Do you look at just significant events and where things have gone wrong, or do you look at actually people's everyday work and people's everyday, and how, by understanding those, you begin to say, well, actually, things made sense at that point, but this is how we can strengthen it. And by creating spaces that you can look at how we went about something that went well and how we achieved safe care, as well as moments when things didn't go quite as well, begins to get an environment that you feel safe to talk about things. And that doesn't just happen. That's in the practice. That's taken 20 years to get to a point where you feel very safe to bring things up, because you understand that's how we frame things and we're looking after each other. So I think patient well-being and staff well-being is absolutely paramount to the success of patient well-being. And that, I think there's a recognition of that, and that requires resourcing.
Just going to say, I know Tom mentioned chronic kidney disease earlier in our conversation, and that's a really interesting condition, diagnosis, in the sense that, when I look at our register, even 2 or 3 years ago, our prevalence, the number of people with chronic disease labelled as having chronic kidney disease, was around 2%. And through quality improvement work, we brought it up to just over 4%. But the biggest challenge we had was actually trying to explain to patients what that actually means in terms of their life and the complications it can lead to, and how we can try and avoid that, and the kind of issues around prescribing of non-steroidal anti-inflammatories and what that might mean to them, or when they go into hospital, what that might mean to them. It is actually quite a challenge, because it's a very new condition for people to understand. And I think there are lots of challenges around how we communicate that as a condition that people understand when largely it's asymptomatic. You don't know you have it until it's a real problem. And how you communicate that is a real issue for me.
Sorry, I mean, without getting drawn down into a CKD, chronic kidney disease lens, there is something about labeling and how to navigate that challenge of sort of how to frame things better, really, and how to place certain diagnoses in clinical context and in context of people's lives. And there are perhaps better ways to frame things that have been come in with a medical term of chronic kidney disease, that you may want to frame things more around kidney health, as an example of, and then begin a conversation that is less frightening, less problematic, places it in the context of maintaining someone's vascular health and general health, and also safety in medicines. So there are perhaps better ways of framing things than other ways that historically are, and that's created a challenge because people can avoid then when you're not clear on how to frame it, you might avoid actually having the conversation in the first place, and that itself, by avoiding it, isn't biopsychosocial in approach, because the medicine really matters. So this sort of talk of the medication for people is a really important part of a biopsychosocial approach to improving people's lives.
How do we begin to overcome that challenge then? Is it a factor of just more training?
Two quick responses to that would be, I think, multidisciplinary engagement in how you think about things. So not getting caught in, it being entirely a secondary care thing or a primary care thing or a patient, and multidisciplinary in the sense of, having patient voice and expertise in understanding and driving how you might improve talking about things. So I think that's fundamental. I mean, it's central, and I don't think, and in the history of medicine, it's still probably relatively early about recognizing the importance of people's voice and design of and strengthening systems of care.
Alongside that, research carried out by one of our colleagues, Sude Chiragi-Sohi, who concluded that estimating diagnostic error is, as we said, challenging for absolutely many reasons, but the fact that how we, because we're a research organisation, how we measure diagnostic error, it can be very complex. And how do you think having good measurement instruments plays into the idea of improving diagnosis?
Yeah, having good instruments is helpful, but because of the complexity of it, we're probably not going to get a perfect instrument. And I think, for example, when we did our study of avoidable harm in primary care, I was sort of thinking, well, if the end result was plus or minus 50% of what we found, would that make a lot of difference? The most important thing, I think, is actually what we have found from it. What are the different types of errors, the different categories of error, which parts of the process, care process, do they most affect, and most importantly, what are likely to be the most important solutions. So while there's still room for doing more, I think the work that Sude's done and the work that we've done on our avoidable harm project, and of course work done by others around the country and around the world, we've probably got enough there to be saying we've got a pretty good idea what the problem is. And I think that focusing our research around the solutions, I think is going to be one of the most important things for us to be doing.
There's something about the solutions not being transactional in nature, perhaps, or sort of. I mean, there's a risk that we can be showing on paper that we're improving out care, by metrics and sort of that, but it can look, we achieve the incentive for the hospital incentive or the primary care incentive to improve processes of care, and that's important. But it's important that it's not the the way that we go about it is relational and relationship based and person centered, as opposed to being it looks good on paper, and there's a real risk that we can be seen to be doing the right thing but not necessarily have missed the point in the process.
Yeah, and in terms of solutions, one of the things we've not touched upon so far is the importance of continuity of care. So we found that in 14% of the significant harms we identified, there was a problem in relation to continuity of care. It can cut both ways. There can be a risk that actually, as a single practitioner, you can go down the wrong route and keep seeing one again and again and again. But then Umesh made the point about, the 3 strikes and you're out. 3 times a person's seen you about this, and you need to be thinking again. But overall, numerous research studies, including systematic reviews, demonstrate a strong association between having continuity of care and better outcomes, including reduced death rates for patients. And of course, we're in a difficult position for that in general practice, but we do need to be identifying those patients where continuity of care actually is likely to make a difference. So we may not be able to provide it for everyone, but to recognise that for some people, and it's likely to people who've got the most complex problems, or where you really do need to be the person who's following this through, where that makes the most difference. So I'd like to make a particular shout out for that and the importance of it.
Or at least in my reflection, in terms of what's happening in primary care within the practice level, is what I'm getting good at is coordinating continuity of care.
Yeah.
Because there's so much information coming in from so many different healthcare professionals. What I need to ensure is that the person is getting the right care at the right time by the right person. So continuity matters in the context of knowing that actually, if the person isn't in a position to be able to inform healthcare professionals about where they're at in terms of their care. And this is really important for people who are vulnerable, for people, for example, with dementia and people with learning disability, where someone needs to take control of what's happening to them in some capacity. So if there isn't a carer, then there needs to be a healthcare professional that takes overall responsibility for coordinating that person's care across the different healthcare systems. And more importantly, the focus for us is to think about providing care within the person's home, rather than thinking about primary care as being where most care happens. And we have so many of our patients who are now housebound or living within an environment that requires us to provide care at home, that this coordination of care is a key element of how we do that now.
Yeah, no, I mean, agreeing with this, it's sort of, and thinking about we have a housebound team now, and the nurse colleague is about sort of chatting with her recently, that there'll be an aspect of how you hold people, and that you take responsibility for holding people individually as a practitioner and as a team. In doing so, you begin to understand somebody in their context. You identify key issues of that moment. You make a plan with that person, and you see it through. And in pressurized systems, and the NHS, if we look at sort of the policy that the NHS is broken at the moment, that's reflecting workforce pressures. There's a risk when you're having to make quick decisions and you're uncertain around things, because uncertainty is there. The risk is that you just push the problem to someone else, or devolve it, dilute it, defer it, and therefore not really get a handle on it. And it's resourcing that handling and holding of people that maybe needs to, and as Tony said, sort of identifying the groups of people and people that have got complex health and care needs that require that holding, support and planning, and seeing through.
One other thing as a potential solution, and that's technology. And I don't want to overplay this, but there are ways in which our computer systems can help us. You need to get the balance right. If doctors and other professionals are being over alerted all the time. That's not helpful. But we have a number of things that can be helpful. Patient last week where I put an entry into the computer system, recognized this patient had a history of cancer, flagged up to me to say this symptom could actually be a problem because of their cancer. Now I think I was on top of that anyway, but that I felt was a helpful intervention. The other thing, which is not quite a diagnosis, but it's actually part of diagnostic delay, is sometimes it feels almost completely inexcusable, but does happen, is where you have planned to refer a patient to hospital, and for whatever reason it doesn't happen. You've done a message to yourself, it's got lost in the system somehow. And again, we have systems certainly on the computer system that we've got that will flag up, do I need to be telling the secretary about this? So you've got someone else to be in on the loop that I am planning to refer this person to hospital. So just recognizing, I don't think it's a panacea, but the technology can help us in some ways with reducing diagnostic error or diagnostic delay.
In terms of technology, it can enhance continuity and sort of, important coding things in the regard when you're confident on a diagnosis, because it begins to hold down the road, a few years down the line. If you've had an acute kidney injury, as an example, you can be aware of that in the context of decision making on that home visit 5 years down the road. In Leeds, I can look in, the technology is really important, because in terms of continuity and also just as a clinical passion for clinical practice, you can look into the hospital, right? If someone's admitted to hospital, you can look in and you can see what's happening to somebody, and get a sense of when they might be being discharged. You can sense what's happened, and that generates, learning, and it also generates and you begin to have an understanding of a person's story in hospital, rather than it's you've sent in, you don't know what's. You wait for them to come out as though it's some black hole that they've gone into.
One of the things it's worth reflecting on is the fact that we're all academics, and as academics and GPs, that there are certain things we need to think about. And one of the challenges for us has been around the fact that actually, when going back to that of creating measures that we can look at, is actually, increasingly what we're doing is training people to be co-researchers, so people with lived experience who can help us develop and design studies that reflect their experience. And I think that's been a real challenge, and this is where I think we're really developing our understanding and developing better studies, research studies, because we're involving people rather than just being academics and clinicians. We're actually involving people with lived experience to tell us what we should be looking at and how we should be looking at, and actually analysing the data and disseminating when it comes to findings. So that's a really important element of creating measures that are important, and how we can disseminate the findings once, when we come to realising the fruits of our labours.
So unfortunately, that's all we have time for today. I want to extend my thanks to Neil, Darren, Tom, Umesh and Tony for their insightful discussion on what patient safety is, what patient safety means, and improving diagnosis for patient safety in primary care. Thanks for listening, and see you at the next episode of Voices for Safety. You've been listening to Voices for Safety, the podcast that explores the forefront of patient safety research, brought to you by the NIHR Greater Manchester Patient Safety Research Collaboration. If you enjoyed today's discussion and want to stay updated on the latest in patient safety, be sure to follow us for upcoming episodes. You can also find us on X, formerly Twitter, at GM_PSRC, and on our website, www.psrc-gm.nihr.ac.uk. Join us as we continue to uncover insights and innovations that make healthcare safer for everyone. Thanks for listening, and we'll catch you in the next episode.